Hey guys. Morning, everyone.
Good morning.
All right, looks like it's 9 o'clock, so I'm going to go ahead and get started. Um, so today, it looks like in your stuff that you had to do, you had some endocrine topics to go through, which I kind of want to focus more on that today. And then there's just a little bit about fluid and electrolyte stuff. So that stuff should be a little bit of just a review for you, I would think. I don't think you should have to focus on that a ton. So I want to, do the stuff that's a little bit more difficult. So hopefully we can get a handle on that. Did you guys have trouble with anything in particular this week? Or did you do okay with everything? Or did you have a hard time understanding anything? Someone going to respond to me?
No, I was good.
You are okay? Okay.
Yeah, I was okay too.
Okay. All right. So this week, so when this gets into endocrine, it doesn't get into everything in the endocrine system. It only talks about Addison's and Cushing's disease, and then it also talks about your hypo and hyperthyroidism. So like there's other things that it's not touching on, so I'm assuming you get that later on in a different class. So we'll just, do what it's touching on in here. All right, so I put up the PowerPoints for you last week so you guys could kind of see what was what. Let me pull one of these up real quick. All right, so let's just start with Addison's disease and see if we can get that down pretty good, and then we'll kind of go from there. So Addison's disease and Cushing's, I feel like that's kind of a hard thing to grasp for a lot of people. They usually seem like they have a hard time with it. So with all of these endocrine disorders, they're kind of opposites of each other. So when you talk about Addison's and Cushing's, they're opposites. So the big thing with Addison's is that you don't have enough of your hormone with this one. So you have damage to your adrenal glands, and it results in you not producing enough of the hormone cortisol, and sometimes aldosterone too. So where are your adrenal glands located at, you guys? Anyone have a thought?
On top of the kidney.
They're actually like right where your kidneys are. They're right on top of your kidneys. Let me see if I have a good picture I can show you. Okay, let me see if I can share this if possible here. Okay, so look at this picture right here. So there's your kidneys, right towards the middle, and that's where your adrenal glands are located at. They're like sitting right on top of your kidneys. So when we talk about Addison's disease, we're not only talking about the adrenal glands, but there's also a couple other organs that are involved here too. So I just wanted to kind of give you an idea of where some of these things are located at. So we have like this feedback loop, this negative feedback loop that happens when our bodies senses that we don't have enough of these hormones in our system. It kicks in and does its own thing to kind of increase the release of this. So I'm going to talk about that here in a second. But the other part that is, related to all of this would be your pituitary gland. And see where your pituitary gland is. It's up in your brain, up towards the front right here. And it's specifically the anterior pituitary, so the front part of it. All right. Go back to the other one here. Okay, so in this PowerPoint, let's just kind of go through, we'll go from there. So you have this 30-year-old woman who comes to the ER with syncope after she stands up. You notice that her skin is hyperpigmented over her joints and on her palms. She tells you she's been very tired and weak lately, and she's recently lost 15 pounds without trying. She has no significant medical history. The ER physician suspects that she may have primary adrenal insufficiency. So then it says, what is Addison's disease? So if you had to answer that, you would just say it happens because there's damage to the adrenal glands. So because your adrenal glands are damaged in some way, they're not producing enough of the hormone cortisol. Okay? And then they ask you, hey, what is the difference between primary and secondary adrenal insufficiency? So primary insufficiency, adrenal insufficiency, is when the adrenal gland itself is damaged. So there's like, let me see if I can show you this. I don't know if this will work very well, but let me try to draw this. So imagine this is your adrenal gland, okay? There's two parts to it. So there's like an inner and an outer portion of it. So the inner part, this part here, this is the medulla. Which I don't know if I can, it's hard to write with this thing with just my mouse. And then this outer part is the cortex. Okay, so the medulla, this part here, this produces adrenaline kind of hormones, so like your epinephrine, norepinephrine. The outer part, the cortex, that produces corticosteroids, and that's kind of what we're getting at here with Addison's disease. So it's this outer portion that is damaged, right? So anyway, what's the difference between primary and secondary? So that cortex, that outer portion is damaged and it doesn't produce enough of the hormone. And sometimes it can be damaged from different things. So like maybe I've had TB, you know, that could have caused it. Maybe I get some type of really bad infection down there and that's what caused it. It could be from cancer. You know, maybe you have a tumor or something on that gland. And then the most common cause of primary adrenal insufficiency is autoimmune disorder. So that's most likely maybe what's going on with this girl here. When we talk about secondary, the secondary cause is going to be a problem with your pituitary gland. And remember I showed you that picture a few minutes ago, and that's up in your brain. So if you have a problem with the pituitary gland, that actually is part of that negative feedback loop that, you know, kicks in if you don't have enough of the hormone. So it can't kick in and do what it's supposed to do if it's damaged. So that could be what's causing your adrenal insufficiency. So sometimes it's because there's a tumor up there. Sometimes it's because you've had previous surgery to your pituitary gland and it's damaged that. And then other times it is because of corticosteroids that you take. Like maybe you have, I'm trying to think of something where you take corticosteroids a lot. Maybe you have, you know, COPD and you constantly are on prednisone or something like that for a long period of time. Well, if you go off of a corticosteroid like that too quickly, if you just abruptly stop it, you can go into adrenal insufficiency. So that would be a secondary cause. So that's kind of the difference there. Does that make sense? Yes?
Yes.
Okay, I guess I'm talking to myself again. No one wants to say anything. All right, so again, this is just talking about the difference between the two, right? And this says about 80% of all cases are because of an autoimmune response that you have. And then here's some of the other causes. I did mention TB, but there's other things. So you could have a fungal infection, AIDS, cancer, you know, there's all kinds of things that could cause it. And then occasionally there'll be things that you study that they'll say there's an iatrogenic, I can't say, iatrogenic cause of it, which means that they don't understand what caused it. It's just, it comes out of nowhere. All right, so let's get into the signs and symptoms then. Or actually, let me tell you something else first, because maybe this will make more sense if you hear about this. So remember I said our body always like kicks in when it notices that we don't have enough of something, or that something's, the amount of something in our body isn't quite right. It kicks in and does things to try and fix that. So same thing here. So let me just tell you about what happens with this negative feedback loop. So we have a hormone called adrenocorticotropic hormone, ACTH. This is a hormone that's made by that anterior pituitary gland. And what it does is it stimulates the adrenal glands down in your kidneys there to produce the hormones, so the cortisol and the aldosterone and all of that. So in your body then, when ACTH levels are low, so when you don't have enough of this adrenocorticotropic hormone, cells in your hypothalamus will kick in and release a hormone, which I didn't write down the name of that hormone, but that's not important. So that releases a hormone which stimulates the pituitary gland to secrete ACTH into the bloodstream. So remember, your hypothalamus is also up in your brain. So it's really the hypothalamus, the pituitary gland, and the adrenals that all kind of work together to make all of this happen. So anyway, again, when your ACTH levels are low, that hypothalamus will release a hormone which will stimulate the pituitary gland to secrete ACTH into the bloodstream. Then your bloodstream will sense that you have this increased level of ACTH, and it's going to make your adrenal gland receptors notice that, which will stimulate them to secrete cortisol. So as this keeps going and your cortisol levels keep going up, then it's going to start slowing everything down. So then it'll sense that you have a lot of it, so then it'll start slowing down again. So then the hormone that gets released from the hypothalamus will slow down ACTH from the pituitary gland, and then your ACTH levels will start to fall. So this is that negative feedback loop that I was talking about. Okay, so back to Addison's disease. When you have signs and symptoms of this, there's a ton of signs and symptoms, but there's certain ones that I want you to really pay more attention to because they really are significantly different than anything else you'll see. So with this, one of the things that you definitely should pay attention to is that hyperpigmentation, because you don't see that with anything else. That's totally different than all the other endocrine disorders. So your skin will look totally different. It'll look like this bronze, yellowish, orangish look to you. If you guys have seen pictures in the past of President Kennedy, John F. Kennedy, when he was alive, he had that. He had Addison's disease, and he had this hyperpigmentation to his skin. He always kind of looked like that. So that was one of the things that I want you to remember. A couple other things that are significant for Addison's disease that you should probably pay attention to. You can get weight loss with this. You can have postural hypotension. So this means that when you change positions, you have a low blood pressure and you can pass out really easily. So you'll get dizziness episodes. A couple other things that I want you to pay attention to are about labs. So specific to this, you're going to have a low sodium, you are going to have a high potassium, and you're going to have a low blood sugar. There's a couple other lab things too, but those are the ones I want you to really focus in on to really remember this.
Can you repeat?
So, obviously there's a lot of other symptoms. So let me show you this one picture I have too, because this might help you remember. To me, sometimes if I have a picture of someone that has it, it helps me remember it better. So here's one of those pictures. So this poor lady, she's got the bronze pigmentation of her skin. There is like something about changes in your hair. They say that sometimes you'll lose some of your hair, like the distribution of it won't be as good. You do have some GI disturbances. So remember we said you can have anorexia, sometimes nausea, vomiting associated with this. You have this profound weakness and fatigue associated with this. There's the postural hypertension I was telling you about, the hypoglycemia, the weight loss, and then look in that box down here. So dehydration, vascular collapse, renal shutdown, low sodium, high potassium. So again, things to focus on for signs and symptoms: hyperpigmentation, low blood pressure, low blood sugar, low sodium, high potassium. Okay. All right, so anyway, this says manifestations are slow onset. So they, you don't have all of this all at one time. It comes on over a period of time. So here's an example of that bronze pigmentation of your skin. All right, so this says, for what additional clinical manifestations will you assess her for? And we just talked about some of those things that you'd be really focusing in on. Okay, other manifestations. So they say you can have abdominal pain, diarrhea, headache, orthostatic hypotension. You can have a salt craving. And you have that because you are so dehydrated. And also joint pain, I guess, can be associated with this. All right, so people who have Addison's disease, they'll have it for the rest of their life. There's nothing you can do to get rid of it. But there is something called Addisonian crisis that can happen too that we need to talk about. So this is kind of something that can happen to the extreme. So this will happen as a result of severe stress. If they get like a bad infection or something, they could go into this. If they have salt deprivation where they're not taking in enough salt, if they have overexertion or cold exposure, some of those things can trigger you to go into this Addisonian crisis. So what happens here is you have okay, so basically what happens is if you have untreated Addison's disease, so maybe you don't realize you have it, so you haven't treated it, or one of those things that I just mentioned could make you, like, trigger you to going into this episode. So what happens is all of your symptoms are going to be to the extreme now. So how we said you could have pain before? Well, now it's going to be like really bad pain. So pain in your lower back, abdomen, and legs. You could see really severe vomiting and diarrhea, and your dehydration could be even worse. You could have loss of consciousness with this. And then your potassium level, how normally it's high, it's going to be super high now. So that's going to be a problem. And the sodium might be really low, like more so than normal. So what you're going to do for treatment for this is usually you're going to give, you're treating the symptoms basically, so if I'm nauseous and vomiting, I'm going to give them stuff to help with that. If I have a super low blood sugar, I'm going to give them stuff to bring their blood sugar up. If I'm really dehydrated, I'm going to give them IV fluids to help fix that. So anything you do is just aimed at the symptoms, basically. And then you also have to remember this person is low in their hormones, right? So we need to give them IV injections of hydrocortisone because that's going to help fix this, because that's what is really the problem. It's so low that you're going into this crisis. So just remember, Addisonian crisis then is, either someone who doesn't realize that they have Addison's disease, or it's someone who had some type of triggering episode that put them into this. And all of your symptoms that you would have, just like you would have with Addison's disease, you'll have them to the extreme. Okay, so this says what clinical manifestations displayed by SC would indicate that she's experiencing an acute adrenal insufficiency. All right, so I don't know if I don't think I said this, but let me step back a second and tell you a couple other things about Addison's. So with Addison's disease, there are a few different hormones involved. So it's not just the glucocorticoids. So we also have mineralocorticoids and sex hormones that are involved here. So let me tell you what each of them is responsible for real quick. So mineralocorticoids, this would include your aldosterone. So this is aldosterone increases sodium absorption and causes potassium excretion in the kidney. So if you are deficient in aldosterone, you could see why your potassium would be up, because you're holding on to it now. Glucocorticoids. So that's what we're normally focusing in on, is those. So what happens with those, that has to do with your cortisol. So your cortisol affects your glucose, protein, and fat metabolism. It's your body's response to stress and the body's immune function. So that's kind of what that is involved with. So again, that's your cortisol. And then your sex hormones would be androgens and estrogens. So this has to do with some of your sexual characteristics, like, maybe if someone is deficient in one of these, or if they have too much of one of these, you're going to see like certain symptoms that go along with it. So when we talk about Cushing's has too much of the hormones, so then you're going to see more so problems with those. So anyway, with complications then, so during an acute adrenal insufficiency, again, you're going to have some really bad complications that go along with this. So you can have confusion, weakness, hyperkalemia, hypoglycemia, hyponatremia. All right, what diagnostic studies would you expect healthcare providers to order for this girl? So what they're going to do is they're going to draw blood, and they're going to look for some of those electrolyte abnormalities, for one. And then they also want to look at those hormone levels. So they'll draw an ACTH level and a cortisol level. There's actually an ACTH test that may help them be able to figure out if that's what this is. And I've actually had to do that before with a patient. It's called an ACTH stimulation test, and it involves measuring the level of cortisol in your blood before, and then you administer this ACTH, and then like 30 minutes later you draw the blood level after. So that's an ACTH stimulation test. Actually, I think they talk about it here. So increased blood cortisol levels mean that it's normal. Little or no increase in cortisol levels means Addison's disease. This also talks about a couple other tests that they can do. There's a CRH stimulation test, which it talks about your ACTH hormone in particular. So high levels of that with no cortisol indicates Addison's. And then the absence of ACTH or delayed response would be secondary adrenal insufficiency. Some other things that they could do for diagnostic tests, if they're really concerned, especially if you have a really high potassium, anytime you see someone with a high potassium, you're worried about their heart because high potassium can cause arrhythmias. So that's why you see maybe they would do like an EKG or something to do, see what's going on with this person. If you were concerned that maybe this person had a tumor or a cancer that was causing this, then maybe you would do imaging tests like a CT scan or an MRI, because that's going to show a little bit more detail about those things. Okay, so look at this girl's labs. So she has an increase in her ACTH, a decrease in her cortisol, decrease in sodium, decrease in glucose, increase in potassium. So that's why I want you to remember those things in particular, because that's like a typical Addison's disease person. All right, so this says, do these values reflect primary or secondary insufficiency? It's going to be primary. And then what treatment would you expect the healthcare provider to prescribe? So let's talk about the treatment. So with treatment, because you have these low cortisol levels, you need to fix that. You need to give that. So oral corticosteroids, these people would be on. So it's going to be things like hydrocortisone, prednisone, or cortisone acetate. Any of those types of things would be used to replace their cortisol levels. Now, if this person also has an issue with their aldosterone being low, then you will also see them be treated with fludrocortisone. This is going to be used to treat that low aldosterone. And a couple of things about that, you want to monitor their weight, their blood pressure, and their electrolyte levels while they're on this. And while they're on it, they could see some mild peripheral edema that's associated with it. And then the other thing on this slide, it talks about increase their dietary salt intake. This is important while they're on, or while they're having an issue especially. So believe it or not, these people actually have like salt tablets that they can take. And they have an understanding with their physician. Their physician talks to them about how to treat this and what to do when. But they tell them that they need to take more salt during times of stress. So, your patient would be unable to retain salt naturally because of all of this dehydration that they're undergoing. So, you want to make sure that they take these salt tablets to, get back to a normal range. Again, this person is always going to have Addison's disease. They're not going to get rid of it. So you need to make sure that they wear a medic alert bracelet so that people know that they have it. You need to make sure that they understand this is lifelong therapy that they have to be taking, these medications. They can't just go off of them. Again, this is talking about Addisonian crisis there. All right, so this says when a patient with Addison's is hospitalized, nursing management focuses on monitoring, and correcting their fluid and electrolyte imbalances. You look at their vitals and their neurostatus really closely. Again, just because we're just talking about endocrine right now, it does kind of get into a little bit about the electrolytes within this. So like here, because this person has a low sodium, if it's super low, that can really affect their neurostatus. It can make them be confused or to the point where, they have seizures or whatever. I mean, you have to really watch that. Other things this says, we want to keep track of their daily weight, intake and output. You want to take a complete medical history to determine drugs that can potentially interact with corticosteroids. So things like cardiac glycosides, oral contraceptives, anticoagulants, and NSAIDs all have the potential to interact with corticosteroids. So you wouldn't want to take those together. You also want to look at their blood pressure and note any changes in that, look at their weight, and see if any of that is getting any better or worse. Now, going back to this for a second, you always have the chance of going too far the opposite way. So as you're taking some of these medications, if you end up getting levels that are too high, you can end up going into Cushing's syndrome because now you have too much of the hormone. So that's why you want to really keep a close eye on some of those things. Okay, I don't know where that one slide's at. I must have passed it. So since this person is on corticosteroids and they're on this for life and they're taking them because they have this issue with their Addison's disease, you need to know and be familiar with some side effects that you could have from corticosteroids. Trying to find it. Here we go. All right, so check this out. So with corticosteroids, you can have delayed healing. So, if you have a wound or something, it's not going to heal as quickly as someone else who's not on corticosteroids. You can have problems with your blood sugar. They can shoot your blood sugar up. So you need to watch that. It can also affect your blood pressure, your potassium, and your calcium. It can make those low. You're going to be more susceptible to infection. So if you are around someone else who's sick, you could pick up their bug really easily because you just don't have a good immune system right now because of that. So those are some of the things that I really want you to focus in on because that's important to know for future for you. And look at some of these. I mean, there's a ton of things. Look at this. You can get peptic ulcer disease. You can have much muscle atrophy and weakness. You'll have that moon face from this, protein depletion, acute risk for adrenal crisis if you stop the therapy abruptly. There's all kinds of stuff. So just really, make sure you know those and be aware that when someone's on corticosteroids, those are some of the things that you need to watch for. All right, and then this just talks about dietary and needs and that type of stuff. So I'll let you guys read through all of that. I won't go through all of that stuff. And then the audience response questions. All right. Do you feel like you have a good handle on Addisonian or Addison's disease or not?
Nope. Miss Silk, can you hear us? Hello?
All right, guys. Well, since no one's talking, I'll keep going.
Hello, we can hear you.
All right, I'm going to show you, instead of doing those PowerPoints, I'm going to show you my other one from my other class. Let me find the right spot to get to, but All right, someone talk real quick.
Hello?
Okay, I can hear you now. It's my volume. That's my problem.
Oh, okay.
It got hit accidentally. All right, I'm going to put on my other PowerPoint, so we'll just go through Cushing's with that. I just have to find Cushing's in here. Here we go. Okay, so Cushing's disease. Now, sometimes in questions, when you see questions about it, you will see it called hypercortisolism. So, you know, when we said Addison's disease, we said it was adrenal insufficiency. So with this, it's hypercortisolism. So what's happening here is it's caused by oversecretion of your hormones of your adrenal cortex. So again, it's the same hormones we were just talking about with Addison's, but now we have too much of those. So this could be the result of a tumor in your pituitary gland that would cause an increase in the release of that hormone. It could be, you know, a couple other things as well. But anyway, whatever it is, it's causing your hormones to increase their production. So Cushing's syndrome is going to result from long-term use of glucocorticoids to treat other syndromes like asthma or rheumatoid arthritis. So sometimes if people have been on, you know, corticosteroids for a long period of time, they'll get that. So again, the hormones that we're dealing with would be our glucocorticoids, which that's kind of what we're focusing in on, like we're having too much cortisol here. And then sometimes it's the mineral corticoids, which is aldosterone. So if we have too much of that, that's going to cause increased sodium absorption and cause your potassium to be secreted by your kidneys. Okay, so let's look at some of these pictures here. So for signs and symptoms, with this one, there's quite a few. And I want you to focus in on certain ones as well, and I'll kind of point those out as we go here. So with this person, someone with Cushing's is going to look really big around the middle, and then their arms and their legs are going to look really skinny and tiny. So remember their shape, okay? So why do you think their arms and legs are so skinny and tiny? What do you think's going on there that make them look that way?
Is it that they are losing fat from their hands and feet?
Yeah, they have muscle atrophy going on. So their muscles are very small. So yeah, they don't have a whole lot of fat there at all. So all of their fat's kind of around their middle. So this person is generally going to look very unhealthy. Okay, so they'll look overweight, and then their face is going to look different. So they're going to have what they call a moon face. So it's going to be like really round looking. On your face, you can see sometimes they'll have like the rosy red cheeks. Sometimes people will have a lot of acne associated with this. But yeah, so that the shape of their face, the moon face, that's significant. So remember that. Then in this picture, I don't know if you can see very well in this, but do you see on the left-hand side, it says buffalo hump right here in the middle? So a buffalo hump is just in between your shoulder blades, basically the upper part of your back. That's going to be like rounded right there. On their belly, when you're looking at their belly, you're going to see stretch marks. That's definitely something that you'll see. With their skin, sometimes you'll see they'll have like a lot of bruising and maybe openings and stuff on their skin from just not healing well, right? So poor wound healing. So you remember when we talked about these hormones with Addison's, I was telling you there's like 3 different hormones. There's mineralocorticoids, glucocorticoids, and sex hormones. So this is where you see the difference with the sex hormones. So if this person's producing too much of these hormones, now you're going to see some differences. So women with Cushing's can have thicker or more visible body or facial hair. So like where you would normally not see facial hair in a woman, you're going to see a lot of it now with this Cushing's. Sometimes it'll affect their periods, so they can have an absent or a really irregular period. And then men with this can develop decreased libido, decreased fertility, and erectile dysfunction. So that's because of those sex hormones. All right, and then let me see if there's anything else there I want to tell you about before we go on. All right, so with the signs and symptoms, so remember the moon face, the buffalo hump, the small arms and legs, so they have that muscle atrophy. You're going to see stretch marks on their skin. They're going to have a high blood pressure usually, a high blood glucose, a high cortisol level. And then here's another thing I want you to remember. So they are really at high risk for fractures. So their small arms and legs just I don't know if that'll make you think of it or not because they have such small arms and legs, but they're at high risk for fractures. So they can have bone pain and stuff associated with this as well. All right, so with causes, Cushing's syndrome is caused by an outside source or a medical treatment like glucocorticoid therapy. And then Cushing's disease is caused by an inside source. So maybe it's your pituitary gland that's just, acting up and producing too much of the ACTH, which that'll cause the adrenal cortex to release too much of that cortisol. So that's kind of what's going on there. All right, and then with complications, these are some of the things that you'll see because this person is so unhealthy. So they're at risk for osteoporosis, they're at risk for high blood pressure, type 2 diabetes, frequent and unusual infections, and then that loss of muscle mass and strength. All right, and then to diagnose this, sometimes it's hard to diagnose. So what they're going to do is they're going to do some urine and blood tests, because we're trying to measure these hormone levels for one. And then also we want to measure some of the electrolytes too, because that's going to help us figure this out. There is some type of saliva test, I guess, that they can do to figure out if this is Cushing's. And then, of course, if they think that there is a tumor or something going on somewhere that's causing this, they might want to do some imaging to look at that a little bit closer. So with treatment, your treatment is going to kind of depend on what the cause of this is. So the treatment is designed to lower your levels of cortisol in your body. So if this is because you have a tumor somewhere, then maybe they're going to do surgery to try to get the tumor out. Or maybe they're going to do chemotherapy to mess with the tumor to try and shrink it up or something, or radiation. If they do surgery, they could do like an adrenalectomy and take your adrenal glands out if there's a tumor there. Or they could do a hypophysectomy, which is removal of your pituitary gland if it's having to do with that. So yeah, I mean, there's a ton of different, surgery options you could do. But then if this is just something that you need to treat like kind of conservatively, then you're going to do medications. So some of the medications that people are on would be ketoconazole, Mitotane, and I can't say the last one, metyrapone, something like that. So those would be some of the other ones. All right, so in your ATI book, your MedSurg ATI book, there are a couple of chapters on these topics. So the Addison's disease chapter is chapter 81. It's page 523 in that book. And then the Cushing's chapter, I think, is in front of that. Let me see. Yeah, it's chapter 80, and that's page 517. So that's the specific stuff about that.
Is it for from the fundamental book or the
No, MedSurg.
Oh.
Okay. All right. So then the other group of stuff that you guys would have had to talk about would be the thyroid stuff. So let me see if I can find that real quick. I'm just going to show you my PowerPoint here because it's just easier for me instead of going through that other one. This is one that I do for my other class that I teach. Can you guys see this okay?
Yeah.
Yes.
Okay. All right, perfect. Okay, so hyperthyroidism and hypothyroidism. That's what we need to talk about now. All right, so our thyroid gland. This is just like a butterfly-shaped organ that's right here in your neck. It makes our thyroid hormones, and the thyroid hormones that we're talking about would be thyroxine, which is T4, triiodithyroxine, which is T3, and thyrocalcitonin, which is calcitonin. Makes those three things. We're mainly concerned about T3 and T4, though, with this particular disorder. So, again, just like with that Addison's disease that I was telling you about, there is like a negative feedback loop that happens with our body with our thyroid stuff as well. So, secretion of these thyroid hormones, T3 and T4, is regulated by this negative feedback loop. So again, we're concerned with the anterior pituitary gland. So remember, that's up in our front part of our brain. And so when T3 and T4 levels are low, this kicks in. So the TSH is called thyroid stimulating hormone. That's something that's going to be released by the anterior pituitary gland in our brain, and it's going to cause us to make more T3 and T4. So by that TSH being secreted by the anterior pituitary gland, it makes your thyroid gland make more T3 and T4. So that's kind of what goes on with that. When your body detects that it's low, so the TSH kicks in to make more T3 and T4 from the thyroid gland. Now, where calcitonin comes into play is it inhibits mobilization of calcium from the bones, and it blocks low levels of blood calcium. Dietary intake of protein and iodine is necessary for the production of thyroid hormones, so you need a lot of iodine in your system to make this. So where do you get iodine from, you guys?
Salt.
Salt, yeah. So table salt, basically. And it's funny because you need that for this, but generally we try to get people to stay away from it as much as possible. Okay, so when we talk about hyperthyroidism, when we're talking about this, we're talking about our metabolism. So our body is making too much of these hormones, the T3 and T4 specifically. So it's causing our metabolism to speed up, and it makes us do a ton of things. So we're in this hypermetabolic state. All right. So with our signs and symptoms. So all of your signs and symptoms are going to be like things are speeding up, I guess you could say. Let me see if I have that one picture I can show you again. That would be helpful, I think. look at this top picture right here of this hyperthyroidism. So in this picture, this person is hot. They have an intolerance to heat. So that means no matter what they do, they are constantly feeling too hot. So like this person has this fan on them and they're still sweating, right? So intolerance to heat is one of your signs and symptoms. Other things that you're going to see, think about, hey, your metabolism is speeding up. So what would you see? So you're going to see tachycardia. So you're going to see a high blood pressure. You're going to see weight loss because you are burning through all of your calories really quick because all of your metabolism has sped up so much, right? So it's weight loss. And as far as other things like kind of speeding up per se, you'll see tremors. So they may have some tremors. They can have diarrhea. So their GI system is kind of like acting up and speeding up too much. And then there's some weird things that are associated with hyperthyroidism, like your hair looks a little bit different. They say fine, straight hair. And then sometimes you'll see people that have hyperthyroidism that have it caused by something called Graves' disease. And Graves' disease has specific signs and symptoms associated with it. So you'll see what they call exophthalmos, which is bulging eyes. So I'm sure you've seen pictures of people with their eyes that look like they're bugging out. Other things associated with it that they don't have on this picture here, associated with Graves in particular, would be something called pretibial myxedema. And this is something that is where you have dry, waxy swelling on the front surfaces of your lower legs. So those are some of the things that you'll see with signs and symptoms. And I don't know, if you guys like those pictures, I can post them on your site. I just wasn't sure if you would like those or not. I don't know, I like some. Okay, so with causes, so probably one of the most common causes of hyperthyroidism is autoimmune disorder. So that's your Graves' disease. So that's probably the most common cause that you'll see of hyperthyroidism. So remember what autoimmune means. This means that your body's trying, like seeing something as foreign and it's trying to attack itself. That's what's going on here. So with Graves' disease, again, it's not something that you'll see everyone have, but it's a pretty common cause here. It tends to run in families, and you see it more so in women than you do in men. A couple other things that could cause it would be a toxic nodular goiter. So I don't know if you guys have ever went to the physician to have a checkup, and then your physician like kind of feels around your thyroid like this, and they'll tell you to swallow. Do you know what they're looking for?
Goiter.
Yeah, they're looking for goiter, plus they're looking to see if you have any nodules on your thyroid as they're feeling it right there, because as you swallow, they can feel it better. So someone who has this toxic nodular goiter, they have this overproduction of these hormones, and it causes these little nodules all over their thyroid. So the goiter, I'm sure you guys have all seen someone with that before. So you have this swelling that's like right here, and sometimes it can be really huge. And it can be pretty bad at times. So that is something that is another cause of this. All right, so for hyperthyroidism, it's kind of hard to diagnose. Again, you do need to do blood work with it and do a really good physical exam. But the things that they're going to measure with this are going to be your thyroid hormone levels, and also your TSH level. They're going to look at those in particular. If they think that you have, like a nodule or something on your thyroid, then maybe they'll send you for some further, imaging to look at that a little closer, but typically, it's mainly going to be this blood work. So if someone has hyperthyroidism, they're going to have an increased level of their T3 and T4 and a decreased level of their TSH. Because remember, you need that TSH to stimulate the production of T3 and T4. So if they're making too much of it, they're having an issue with their TSH. All right, this just talks about that. Another thing that they could do for testing, there's like a iodine thyroid scan that they could do. With this, your thyroid gland normally takes up iodine in order to make thyroid hormones. So if they measure how much radioactive iodine is captured in the gland, it can be useful to see if that's what your problem is. So sometimes they might do that as well. Okay, so with treatment, there's quite a few different things that you can do for treatment with hyperthyroidism. So first of all, there's antithyroid medications. And there's two medications in particular that they focus in on. So there's propylthiouracil, or PTU, and there's also a medication called methimazole or Tapazole. So what these do is they work by blocking your thyroid gland's ability to make new thyroid hormone. So these are not perfect medications by any means. So like the PTU, it can cause you to have liver problems over a period of time if you take it for a while. So you need to kind of watch their liver enzymes when they're on that. And then the methimazole, this is the one that's preferred out of the two because I guess it has less side effects. They say if someone takes it and they have Graves' disease, it says in 20 to 30% of patients with Graves' disease, the treatment with this drug for 12 to 18 months will result in a prolonged remission of the disease. So typically it helps really well. Some of the side effects you would see with that methimazole would be stuff like rash, hives, fever, and joint pain. So that's one option for treatment. Another thing that they could do is called radioactive iodine. And I would encourage you guys to read about this in your ATI MedSurg book. There is something specific about it on page 508 in your MedSurg ATI book, so make sure you look at that. So with this, it's given by capsule. And once it's swallowed, the iodine gets into your bloodstream and is taken up by your overactive thyroid cells. This destroys the cells that have taken it up, and it results in the thyroid or thyroid nodules shrinking in size. So sometimes they will do this in preparation, like if they think they're going to have surgery and take the thyroid out, they'll do this first to shrink it down so that it's easier to remove it once they do the surgery. Now the thing with this is it's called radioactive iodine. So when you take it, you're radioactive. So this means this person would have to be isolated from other people for a while. So it doesn't mean you have to be in the hospital to take it. You can be at home, but you need to not be around other people. So in the ATI book, when you read about it, it talks about like you can't eat off of the same plates and silverware as everyone else. You have to have plastic silverware. If you go to the bathroom, you can't use the same toilet as everyone, so you might have to have a bedside commode, because everything that comes out of you or that you touch is radioactive. So you don't want to spread that to other people. So this is only for a short time. You're not on this for like, weeks at a time. It's only for a couple of weeks, I believe. So, but it's no joke. You have to really be careful with it. All right, and then the third thing that you could do for treatment would be surgery. So let's talk about surgery for a second. So if you get your thyroid out, it's called a thyroidectomy. And remember, we said our thyroid's right here in our neck, so your incision would be really small. Essentially, it's just like this. So because your incision's in your neck, some of your worries would be after surgery that, hey, this is right next to my airway. I'm worried about my airway, right? So after surgery, do you think you want to lay this person flat? What do you think?
I don't think so.
Yeah, you'd want to have them up. So it's always a problem. Like if you see a question that says, hey, would you have them flat or not? You always need to have them up. So semi-Fowler's position, you're supposed to avoid neck extension. So like say you have to take that person downstairs for testing or something and you're transferring them onto a cart, you have to really support their head and neck well. You don't want to have any kind of overextension of their neck because that can mess up your incision. The other thing that we're really concerned about that I really want you to focus in on is that you can have a low calcium as a result of having your thyroid out. So have you guys heard of Chopsticks and Trousseau's sign? Did you
I
read
didn't
about
hear
that
the
at all?
first thing, but the Trousseau sign, yes.
Okay, so you've never heard of Chopsticks?
No.
Okay, let me see if I can show you this. So this is kind of important to know. See if I can spell it right. Okay, so look at this picture right here on the right-hand side of the screen. It's a pink picture, and it talks about a listening chopsticks sign. So you tell the patient to relax their facial muscles, and you stand directly in front of them and tap their facial nerve. This is either just anterior to the earlobe and below the zygomatic arch. So kind of like right in here. So like if you follow your jaw up to where your earlobe is, like right in here, this is where you would be tapping. So it says a positive response varies from twitching of the lip at the corner of the mouth. So you see what this guy's doing in the picture. You might see something like that. Or you could see spasm of the facial muscles. So depending on the severity of the hypocalcemia. So the idea is if you do Chopsticks or Trousseau sign, which I'll talk about that in a second here, this is kind of a sign that maybe they might have low calcium. So obviously you would never just rely just on this. You would, check it further to see if it really was low or not. But you need to know these signs because NCLEX is like really big on these types of signs. So Chopsticks and Trousseau's are synonymous with low calcium. I don't know if I can find, let me see if I can find the other one. Trousseau's has to do with the blood pressure cuff. This kind of talks about it, but it doesn't really show it. So with Trousseau's, or actually, here we go. This is a better one. So what you do is you put a manual blood pressure cuff on this person and you pump it up kind of high, and then you leave it on their arm like that, pumped up for like 5-10 minutes or something. So as it's on there for a certain period of time, they are going to start to do this spasm of their hand. You see what this person's doing right here? That's kind of what you would see. So it's like flexion of the wrist, flexion of the metacarpophalangeal joints, extension of the interphalangeal joints. So that would be positive for a low calcium if you saw that. So that's Trousseau's sign. Okay, so again, we're really concerned about this low calcium. So it's, you know, if you did see this after they had surgery, you would treat it and you would give IV calcium, typically IV calcium gluconate. All right, so some other things that you need to think about after surgery if you had your thyroid out. They are also worried about damage to your nerves that control your vocal cords. So it's not uncommon in a question to see something about someone saying, hey, make your patient talk to you after thyroid surgery because you want to see if they have a hoarse voice or anything. Because if they do, then maybe they have some damage to those nerves. Other things just to think about, of course, you're going to watch for hemorrhage afterwards. So they're going to have this dressing right here, and you would expect to not see very much drainage on there. So usually only at maybe a scant amount after 24 hours, and then that's it. So if you see lots of bleeding there, that's a problem. So anyway, that would be another thing to think about. So anytime you see anything about thyroid surgery, thyroidectomy, one of your biggest concerns is going to be low calcium. Other concerns would be, hey, I'm looking at bleeding. I'm always worried about the airway and swelling and everything, so I want to make sure this person's sitting upright. Usually they'll put like an ice bag or something on their incision afterwards. Now the surgery itself, you know, you can have the surgery one day and go home the next day. So typically they don't stay for a real long period of time. And then also, you know, monitor for that hoarseness of their voice. So just remember those things about the surgery. Oh, and then one other thing I want to tell you about with hyperthyroidism, which I don't have a slide for this, but there's something called thyroid storm that can happen. So you remember when we talked about adrenal insufficiency, we said that there was an extreme of things that could happen with adrenal insufficiency. Same thing here. So thyroid storm could happen as a result of having your thyroid out. So what it is it's a sudden surge of large amounts of your thyroid hormones into your bloodstream. And it causes a big increase in your body metabolism. So it's a medical emergency if you see this. So other things that could cause it, so like I said, you could see it after thyroid surgery, or you could see it, you know, if someone had an episode of DKA, if they had an infection or trauma, you know, something like that. So those could be things that could kick them off into this. So again, it's just this little squirt of those thyroid hormones into your bloodstream that causes all of your hyperthyroidism symptoms to be really extreme. So again, think of some of those symptoms. So hey, we said we had an intolerance to heat. So now we're going to have hyperthermia as a result of this. So this means my temperature can be out of control, like 104, 105, like it can be really bad. Hypertension. So now maybe my blood pressure is like really out of control, like 180 over 120 something. I don't know. I can get delirium, vomiting, tachydysrhythmias. So remember before we said you could have a high heart rate? Well, now it's like out of control high. You can have chest pain, palpitations from this. There's a ton of stuff. So idea is with this is you're treating symptoms again. So whatever you have going on, you're trying to treat that to fix that. So if it's the high temperature, I'm going to do cooling blankets. I'm going to give Tylenol. I'm going to put ice bags all around them to try and get their temperature down. If it's the high heart rate, I'm going to have them on a cardiac monitor so I can monitor that. I'm going to give them, different medications to bring that heart rate down. So you're treating their symptoms and you're, keeping a close eye on their airway. But then you also have to remember, hey, they have hyperthyroidism here. So we need to give them some anti-thyroid medications. So remember those 2 medications I told you about. So you're going to reach for one of those to give during this episode here as well. So like that PTU or Tapazole, because that's going to help, block the production of these thyroid hormones. Because this person could die from this. So you have to be really careful. All right, so then we get into hypothyroidism. Okay, so hypothyroidism is going to be where your body's not making enough of those thyroid hormones, so the T3 and T4. So your metabolism is really slow with this one. So the thing is with this is a lot of times people who are really at risk for this are older adults, and they get underdiagnosed a lot because their symptoms are often similar to what you would see with the aging process. So doctors will just be like, oh, they're 80, that's why they have that, so they don't even think to test them for this. So women are more at risk than men, and usually, people over age 60 are at high risk. So just kind of remember that in the back of your mind. All right, so let's see if we can go on here. Our signs and symptoms, everything's going to be slow. So let me find my picture again and I'll show you that. All right, so now we're looking at this guy. So this guy with the earmuffs on. So with our symptoms, now we have an intolerance to cold. So we always feel cold no matter what we do. So you see this person has earmuffs and a scarf and all this stuff on, but they still look like their teeth are chattering. They're still cold. So remember with the hair on the hyperthyroidism, it was like thin and long or whatever. Now you have a receding hairline with this one. You have hair loss. So think of like everything being low. So some of those things that you're going to think about would be, hey, I'm going to have a low heart rate. I'm going to have a low blood pressure. I'm going to have constipation now with my GI symptoms, anorexia. You see how it says dull, blank expression? These people tend to really have a hard time concentrating and thinking about what's going on. They feel like they're in a fog all the time, that they can't concentrate. They have lethargy and fatigue. You can see menstrual disturbances. And then with their weight, they're going to have weight gain because their metabolism is really low. So those would be some of the things to think about with hypothyroidism. I actually had a student that had this before, and she said once they finally figured out that that's what her problem was and put her on medication, she couldn't believe the difference. It was so much better. She felt like 100% better. Okay, so with causes, I don't know if I have this. I need to fix this part of this PowerPoint. It's kind of messed up. Anyway, let me tell you about causes. So causes, your number one cause of hypothyroidism would be Hashimoto's thyroiditis. And this is an autoimmune disorder. So that would be something that you need to worry about. Let's see.
What did you call it? Hashimoto?
Yeah, Hashimoto's thyroiditis. So it's Hashimotos, Hashimoto's thyroiditis. Here it is, right here. You see it on the screen?
Yeah.
All right, another cause of this would be, medical treatments. Like say someone got their thyroid out because they had hyperthyroidism. So after you get your thyroid out, you're considered hypothyroid, right, for the rest of your life. So that would mean, that would be the cause of this person. Let's see. Oh, also, it says there are some other rare causes, like maybe your thyroid gland isn't making enough of the hormone because you have a problem with your pituitary gland. That could be something too. So those would be some other causes to worry about. All right, so let's look at diagnosis here. All right, so to diagnose this, you again are going to do those blood tests, and you're going to see with this one, trying to find my right page here. Here we go. Okay, so with this one, your labs were going to look like this. So you'll see a decrease in T3 and T4 and an increase in your TSH. And again, there is that one test that you could do, that radioisotope scan. That is something they do in nuclear medicine. And if you have, it'll be positive for hypothyroidism if people have a decreased uptake of iodine. All right, and then just things to think about with hypo would be, you're always going to be treated with medication with this, and it's usually going to be Synthroid or levothyroid. There are other medications that are thyroid replacements, and I never realized this, but there's actually kind of a long list of them. These are the ones you see most often, so that's why I have these here, but there are other ones too. So basically, when they put you on this, they put you on a low dose, and then they titrate you up over the next couple of weeks because they're trying to see what the right dose is for you. So you're not going to have, you're not going to get rid of all your symptoms right away. It's going to take a little bit of time. So usually once they start to get your good level, you'll start to feel better. Some of your stuff will go away. But you have to be on this medication for the rest of your life. So this is something that people need to be told. This person has to be monitored with their thyroid level every so often to make sure that that's okay. Typically when you're first put on it or they're trying to get the right level, they'll check you frequently. But then after you're on your good level, maybe they just check you once a year or twice a year or something like that, and that'd be it. But there's always a possibility that, that's not quite right. So you always need to be monitoring that. Other things to think about with treatment. So interventions that we could do as a nurse, you would want to monitor their vital signs, make sure those are getting better. You would encourage fluids and fiber to this patient because remember, when we looked at some of the signs and symptoms, we saw constipation was something. So because that's one of their symptoms, if they increase fluids and fiber, they're not going to have that issue with constipation. They also have a problem with their weight, so we would encourage a low-calorie, low-fat diet for this person. And then we always want to tell them to not switch brands of their thyroid medication. So sometimes people will be like, oh, I want the generic version of this. Well, you have to make sure that you're talking to your physician. You just don't do it yourself because your body's really sensitive to thyroid medications, and if a change needs to be made, you need to have follow-up lab work and stuff to be checked to make sure it's being efficient. Okay, so on here, this is saying if you have coronary artery disease or really severe hypothyroidism, Typically, they'll start you on a lower amount of the medication and then gradually increase your dosage. Usually, this is a pretty well-tolerated medication and you don't have a ton of side effects from it. People tend to really do well with it. And usually, once you have your good dose, you feel so much better. It's just like amazing. Okay, so one more thing I want to talk about. There's something called myxedema coma. So this is spelled M-Y-X-E-D-E-M-A, myxedema coma. So just like we talked about with Addison's disease and hyperthyroidism, there is also another thing associated with hypothyroidism that could be to the extreme, and that's this, myxedema coma. So when your hypothyroidism is untreated, like a lot of people out there don't realize they have it, and they do, or when a stressor affects a client with hypothyroidism, like some type of acute illness or surgery or chemotherapy or something like that, it can cause you to go into this. So what happens here is, again, you're really low on these thyroid hormones, so now it's to the extreme, it's so bad. Or like this could even be someone who decided just to go off their thyroid medicine altogether, so now they got super low, you know. So with this, all of your signs and symptoms are going to be super bad. So you're going to have respiratory failure with this, hypotension, like really low hypotension, hypothermia, so your temperature is going to be too cold, bradycardia, dysrhythmia, hypoglycemia, hyponatremia, coma. I mean, it's bad. So again, just like with the other things, we're just treating symptoms. So if it's that I have a low heart rate, I'm going to give something to help with that, and I'm going to make sure this person's on a cardiac monitor. If I have a low temperature, I'm going to try and warm them up. I'm going to use that bear hugger that I have at work, or I'm going to, you know, warm my IV fluids and give them warmed IV fluids. Whatever it is, we're going to treat those symptoms. And then again, because this person has super low thyroid hormones, we're going to replace those. So we're going to give IV thyroid replacement, so Synthroid through the IV. I don't know if that helped you guys or if that made it worse. I hope that helped you. In your MedSurg ATI book, there's chapters about the thyroid stuff as well. So let's see. Chapter 79 is about hypothyroidism. That's on page 513. And then the hyperthyroidism is chapter 78, and that's on page 505. Let's see if we can do just a couple of practice questions together, and then we'll get off here. Let's see if I can find it. This is it. Yeah. Okay, so there's multiple places where you could do practice questions on some of this content, you guys. So you don't always have to come here. This is registered nurse RN, but she has stuff, so you could come here if you wanted to. But you could also go to like nurselabs.com on their under their exams section. There's, you know, different things. So like there's a section of med-surg questions, and you just have to look for endocrine and see if you can find anything having to do with these specific topics. You could also go on ATI and look at the endocrine stuff up there and see if you can answer some things there. So under Learning System RN and ATI, there's a ton of questions you could do. And then also there's that adaptive quizzing that you could do in there that is very helpful. So make sure you do practice questions because I think that really helps. Okay, so this one in particular is about hypo and hyperthyroidism, since we just talked about that. Let's see if we can figure this out. So here it says the blank produces thyroid-tropin releasing hormone, which causes the anterior pituitary gland to produce blank, which in turn causes the thyroid gland to release blank and blank. So this is talking about that negative feedback loop. If you don't know, that's
Is
okay.
it B?
Is it
Yeah,
B? I was thinking the same. I don't know.
So we'll put answers in here, and then at the end I'll hit and see what's correct, okay? All right, so we'll try that. And then a patient reports they do not eat enough iodine in their diet. What condition are they most susceptible to?
Hypo.
Hypo.
A patient has an extremely high T3 and T4 level. Which of the following signs and symptoms do not present with this condition?
Hair loss. Or I think hair loss.
I think it's C.
You think smooth skin?
I'll go for D.
Tolerance to heat.
Which one should I say?
Let's go with D.
Okay. All right, and then a patient's being discharged home for treatment of hypothyroidism. Which medication is most commonly prescribed for this?
Synthroid.
Yeah.
Right.
Okay, you are performing discharge teaching with a patient who's going home on Synthroid. Which statement by the patient causes you to re-educate them about the medicine?
B.
A.
No, B is correct.
I think it's A. Wait.
Okay, let's try A.
Oh,
Yeah, it's A.
Because it says you're re-educating them, so they're
Yeah.
saying something that's wrong.
yeah.
Okay, so the thyroid hormones T3 and T4 play many roles in the human body. Which of the following functions are performed by T3 and T4?
B. C. Who else thinks E is part of it? I think. I don't know for sure.
It's okay. I mean, we're just practicing, so if you don't know something, that's all right.
If I was taking the test, I would pick E.
Okay, let's try it. All right, let's look at 7. A patient's admitted with complaints of palpitations, excessive sweating, and unable to tolerate heat. In addition, the patient voices concern about how her appearance has changed over the past year. The patient presents with protruding eyeballs and pretibial myxedema on the legs and feet. Which of the following is the likely cause of their signs and symptoms?
C.
Hypo.
Which one?
Is C. Graves' disease.
Graves, yes.
Graves.
All right. And then this one says a patient, which I didn't talk to you about this, so you're probably not going to know this. A patient who is in her first trimester of pregnancy is diagnosed with hyperthyroidism. Which medication do you suspect that they'll be started on?
PTU.
And then which of the following are treatment options for hyperthyroidism?
Radioactive.
B is part of it. D is part of it.
So those 3?
What is thyroidectomy?
They're taking your thyroid out.
Oh, okay.
That's the surgery.
Oh,
Does that look okay?
Yeah.
Okay. All right, look at 10 here. So a patient was recently discharged home for treatment of hypothyroidism and was ordered to take Synthroid. The patient is readmitted with signs and symptoms that look like this. The heart rate's 42, the blood pressure 70/56, the blood glucose is 55, body temperature is 96.8. They're fatigued and drowsy. The family reports that they've not been taking their Synthroid since they've been discharged. Which of the following conditions is the patient most likely experiencing?
B.
B.
B?
Yeah.
Yeah, so look how extreme all of these symptoms are. You see what I'm saying?
Mhm.
All right. A patient's being educated on how to take their antithyroid medication. Which of the following statements are incorrect?
Hmm.
Is it maybe A?
Okay, let's try it. All right, a patient with hypothyroidism is having a pain of a 9 or a 6 on a 1 to 10 scale, the right hip due to recent hip surgery. Which of the following meds are not appropriate for this patient? Select all that apply.
Morphine. Fentanyl.
Anything else? What about Dilaudid?
It's also
What drug is that?
it's also a steroid. I think it's like morphine is for pain.
It's for pain. So Dilaudid should go with us. These are all opioids. All right, look at this one. A patient is 6 hours post-op from having their thyroid out, thyroidectomy. The surgical site is clean, dry, and intact with no excessive swelling noted. What position is best for them to be in?
Am I forward?
Slowly.
B?
D, you said?
It's semi.
Yeah,
I think
D.
A.
Probably either one of these would be okay, honestly, but obviously they're only going to have one. But
that's the
yeah,
problem here.
the thing is you don't want them to be flat. So either one of these would be okay in real life, okay? Just so you know that. All right, so which of the following signs and symptoms cause concern and requires nursing intervention for a patient who recently had a thyroidectomy?
I'll say
Would it be A because of the temperature?
I think so. And it's not just the temperature, it's everything. I mean, look at all of this.
Okay.
So
because
what
you were saying
do you think's happening here to make this happen? So they took their thyroid out. So why would they have all of this stuff being high?
Thyroid storm?
thyroid
Thyroid
storm.
storm, yes. Okay, so blank is an autoimmune disorder where the body attacks the thyroid gland that causes it to stop releasing T3 and T4. The patient is likely to have typical signs and symptoms of hypothyroidism. However, this may present with what other sign as well?
I will say the Hashimo, whatever.
All right, and then which of the following side effects are possible for a patient taking an antithyroid medication?
A.
And then how about this last one? Patient is receiving radioactive iodine treatment for hyperthyroidism. What will you include in your patient education to them about this type of treatment?
A.
All right, let's see what we got right. Oh, look at that, you guys. Nice. All right, so
Wow.
That's good. All right. So again, you can go on here on your own on, registered nurse RN. She's got quite a bit of stuff on here. So that might help you a little bit with some of these things. Some of her questions are good. Some of them aren't as good, but it's something at least. So when you do this, again, you just hit submit and it'll tell you how many you got right or wrong. And usually it'll give you a little bit of something about why it's right or wrong too. Okay. All right. I was going to ask you guys, what do you guys have going on Monday? Do you have another class or a lab or a clinical or anything?
We just have, some of us have clinicals on Monday,
What time?
9:30.
And I know everyone works, so I'm just trying to get at, I was going to see if we could all meet together to do some kind of review for the test.
Oh, yes, we can.
But I want to make sure I get the most amount of people is what I'm getting at. And I can only do it on certain days, so I'm just trying to figure out what would work.
Yeah,
Because
Monday's fine with me too.
I could do it, like does someone have to work Monday though? Does anyone have that problem?
We work in the evening, so daytime may not, I will talk for myself, will not conflict for me. I'll be available on Monday.
Yeah, but I don't want to conflict with your clinical at all. So
After clinicals,
when do you guys get done with your clinical?
I think after 12, because most times she'll let us come back at 12. So maybe by 1 o'clock we should be done with everything.
So like 1 o'clock or something would be
Yeah.
okay?
Yes.
Does that work for everyone or not?
Yes.
Krishna, you don't have any issues with work or anything?
No, I could do Monday.
Okay. All right, so this is what I want you guys to do then. Over the weekend, look at your stuff really well and see if there's something that you're having a hard time with or you can't really quite get, okay? So on Monday when we get together, we'll go over, kind of things that you need to know. And then later today, hopefully later today, I'll send you your things to know for the test, so you guys can start looking at that too. But we'll plan on Monday at 1 then. And I'll send you guys a Zoom invite for that.
Okay.
Okay? So I just want to make sure you guys feel better about this test. And then like some of the other stuff that I didn't go over today in class, like all that, electrolyte and all that, we'll go over that on Monday. It'll be fine. I don't see you having issues with any of that stuff. Okay?
Okay.
Alrighty.
All right, so we'll plan on meeting here at 12:30 today for our lab. What I'm going to do with you guys, I'm going to do just a little bit of math to just prepare you for your upcoming test. And then I'm going to focus today in lab about your ATI fundamentals a little bit. I think we should start thinking about that, getting you guys ready for that too. So we'll kind of focus on that in lab today.
And last week you said you were going to create a section for the ATI. Maybe having a hard time navigating where it is. The one that we had to upload, not the external ATI, like the.
What are you talking
I
about?
don't even. So we have to upload, the
Oh, for
posting.
templates?
Yes.
Do you want me to show you real quick?
Yeah.
Here, let me get on there and I'll show you.
Because the remediation one was on there, but for the other ones we were supposed to do, I'm not sure where to get it.
Okay, so this is supposed to be student view, like what you guys would see on your ATI. All right, so are you just talking about the templates? Is that what you're talking about? Because I'm not sure.
Not the templates. I mean, where we have to upload the scores and stuff on Canvas, not on ATI. I mean, after the completion
Oh, okay, here. Let's look
for
at
the
that.
individualized one, not with the remediation ATI, though.
Oh,
Mock,
for lab, is that what you're getting at?
yes.
Oh, okay. Yeah, I'll make sure that's on there. I'll do that now when we get off here. That's fine.
Mm.
So on Canvas, I'll show you where I'll put it in case it's not already there. See if you can see this. So on Canvas, this is my view, and some things you can't see because I have it like that on purpose. But see where it says Evolve Lab Modules?
Mm-hmm.
I'll put it under there, okay?
Okay.
So for stuff that you have to turn in that's like ATI stuff that I told you to do, you'll put it in there. So I'll put specific spots for it, and then all you'll have to do is click on it, and it'll be a spot where you can turn it in.
Okay.
Okay, so this is under modules.
All right. Thank you.
All right, I'll do that here in a second, so we should be good. All right, so I will see you guys at 12:30, okay? Yes?
Thank you.
Okay.
That's to
All
me.
right, see you shortly. Bye.
Bye.
Bye.